Hi everyone. I hope I'm audible and visible and you're able to see the presentation. Hi, hi everyone. So let us start. So welcome everyone to the class and today's session is going to be a quick and rapid revision for the FMGE exam that is just coming up at the end of this month. And so what we exactly will be doing in this session is we will be going through the one-liners, the important PYQs, and at the end I will also be going through the important images. So this is like going to be a complete revision of everything that I feel that you should be knowing in a case for going through ophthalmology. Before you go through to the exam, I think this will just wrap up your ophthalm. So let me start with the questions. The first set of questions are one-liners, and after that, as I told you, we will be doing a few PYQs and then we will be going to the important images. So let us look at the first question. The epithelium of the cornea is, what is it? Is it a cuboidal epithelium? Is it a columnar epithelium? Is it a stratified squamous keratinized epithelium, or is it a stratified squamous non-keratinized epithelium? So what is the epithelium of the cornea? Is it cuboidal, columnar, stratified squamous keratinized, or stratified squamous non-keratinized epithelium? So what is this? See, ophthal is going to be like, it is one of the most scoring subjects. So you will be having, like last time we had around say 15 questions from ophthal. So that's why if you have more questions from ophthal, it's actually good. Just give me 1 minute. Correct. The answer is, some of you have given me the correct answer. It is stratified squamous non-keratinized epithelium. So please remember, the epithelium of the ocular surface, that is not just the cornea. The epithelium of both the cornea and the conjunctiva, it is stratified squamous non-keratinized epithelium. And when you have like xerophthalmia, what is xerophthalmia? Xerophthalmia means deficiency of vitamin A, right? So in xerophthalmia, what happens to the epithelium? In xerophthalmia, the epithelium changes to stratified squamous keratinized epithelium. So the epithelium of both cornea and conjunctiva is a stratified squamous non-keratinized epithelium, but in xerophthalmia, it changes to stratified squamous keratinized. Both these can come as one-liners. And what about cuboidal and columnar? See, the epithelium of the lens, that is cuboidal or columnar. So we know that the lens has only an anterior epithelium. So if you draw this like this, so for the epithelium of the lens, please remember that the central part of the epithelium is a cuboidal epithelium, whereas in the periphery, the same cells, they become elongated and it becomes a columnar epithelium. So this also can come as one-liner. So in a lens, there is only anterior epithelium, the central part is cuboidal and the peripheral is columnar. Okay, so these are a few important one-liners to remember from here. So let me go to the next question. The next question is this. Where do we get to see Horner Trantas spots? Do we get to see them in flictanular conjunctivitis? Do we see them in vernal keratoconjunctivitis, trachoma, or adenoviral conjunctivitis? So where do we get to see HT spots or Horner Trantas spots? Where do we get to see HT spots or Horner Trantas spots? I think this is a simple question. This everybody will be able to answer. Horner Trantas spots are seen in Where are the HT spots or Horner-Tranta spots seen? Correct. The HT spots or Horner-Tranta spots, these are seen in vernal keratoconjunctivitis, which is also called as your spring catarrh. VKC or spring catarrh, there you get to see Horner-Tranta spots. And another thing is you get to see cobblestone appearance or cobblestone papillae. So cobblestone appearance and HT spots, both of them are seen in vernal keratoconjunctivitis. This is a very common MCQ. And there is also what kind of ulcer is seen in vernal keratoconjunctivitis? It is shield ulcer. So these are three questions that can come from here. Where do we get to see Horner-Tranta spots? Where do we get to see cobblestone appearance or cobblestone papillae? Where do we get to see shield ulcer? The answer to all these questions is VKC, vernal keratoconjunctivitis or spring catarrh. Vernal keratoconjunctivitis or spring catarrh. Okay, let me go to the next question. Where do you get to see Fleischer's ring? Where do we get to see Fleischer's ring? So is it in pterygium, keratoconus, pellucid marginal degeneration, or do we get to see in granular dystrophy? Yes, Fleischer's ring, where is it seen? Fleischer's ring, this is seen in keratoconus. It is seen in, the answer to this is keratoconus. Right? So Fleischer's ring, this is seen in keratoconus. What is this? Fleischer's ring, this is a pigmented ring at the base of the cone. It is a pigmented ring at the base of the cone. At the base of the cone due to iron deposition. So why do we get this Fleischer's ring? This is a pigmented ring at the base of the cone due to deposition of iron, and that is seen in keratoconus. Now, can you tell me what is the pigmented ring at the head of a pterygium called? There is a pigmented line at the head of the pterygium. This also can come as MCQ. A pigmented line at the head of the pterygium, this is called as Stocker's line. This is also a commonly asked MCQ. Pigmented line at the head of the pterygium, this is called as your Stocker's line. So Fleischer's ring is the pigmented ring at the base of the cone in keratoconus. Stocker's line is the pigmented line at the head of the pterygium. Both are important MCQs. ठीक है, नेक्स्ट क्वेश्चन पे चलते हैं. What is the refractive error in keratoconus? Commonly asked question. What is a refractive error in keratoconus? What refractive error do we have? Is it hypermetropia? Is it a simple hypermetropic astigmatism? Is it a myopic astigmatism which is irregular, or is it a hypermetropic astigmatism which is compound? So I think every one of you knows the answer. The answer is irregular myopic astigmatism. It is irregular myopic astigmatism. It's a myopic astigmatism which doesn't follow any pattern. And because of this irregular myopic astigmatism, what is the early sign that you see? This is also MCQ. The early sign that you see in keratoconus because of this irregular myopic astigmatism is the scissoring reflex on retinoscopy. The scissoring reflex in retinoscopy is the early sign of keratoconus, and this happens because of this irregular myopic astigmatism. Again, another important question. Okay, let's go to the next question. What is the drug of choice for HSV dendritic ulcer? HSV is what? Herpes simplex virus, right? What is the drug of choice for HSV dendritic ulcer? So the drug of choice for HSV dendritic ulcer, that is herpes simplex virus dendritic ulcer, is, yes, it is topical acyclovir. And how is this acyclovir given? Acyclovir is given in the form of a 3% eye ointment. This is a commonly asked question. Drug of choice for HSV dendritic ulcer. And also another question or one liner that is asked is, what is contraindicated in HSV dendritic ulcer? The answer to that is topical steroids. Topical steroids are absolutely contraindicated in HSV dendritic ulcer. And topical acyclovir 3% eye ointment, that is the drug of choice. It is acyclovir as 3% eye ointment. Let me discuss two more MCQs. Tell me what is the drug of choice for fungal corneal ulcer? What is the drug of choice for fungal corneal ulcer? The drug of choice for fungal corneal ulcer is, yes, it is natamycin. Natamycin is 5% eye drops. Natamycin 5% eye drops. This is the drug of choice for fungal corneal ulcer. This also comes as MCQ. So drug of choice for fungal corneal ulcer in India is natamycin 5% eye drops. Drug of choice for HSV, herpes simplex virus dendritic ulcer, is acyclovir 3% eye ointment. And in both these, that is active viral and active fungal corneal ulcers, topical steroids are absolutely contraindicated. So here also, if we are asked what is contraindicated, the answer remains the same. It is topical steroids. Okay, let's go to the next question. Phacomorphic glaucoma is caused by, again a very common question which is commonly asked and students get it commonly wrong. So phacomorphic glaucoma is caused by nuclear cataract, mature intumescent cataract, hypermature sclerotic cataract, or hypermature Morganian cataract. So which of the following? The answer is correct. It is phacomorphic glaucoma is caused by, what is this? Here a swollen lens is pushing the iris forward and closing the angle. So phacomorphic glaucoma is caused by a mature intumescent cataract. Intumescent means swollen. So here the swollen lens pushes the iris forward and closes the angle. So phacomorphic glaucoma, it is the most important complication of a mature intumescent cataract. And how about a hypermature Morganian cataract? With this, you people have confused. Hypermature Morganian cataract causes phacolytic glaucoma. So please don't confuse between these two. Phacolytic glaucoma. Phacolytic glaucoma is which this is also called as lens protein glaucoma. Phacolytic glaucoma, what is the other name? The other name is lens protein glaucoma. Here what happens is that the lens proteins leak out and they block the pores of the trabecular meshwork. That is hypermature Morganian cataract causes lens protein glaucoma or phacolytic glaucoma. However, phacomorphic glaucoma is caused by mature intumescent cataract where a swollen lens pushes the iris forward and closes the angle. दोनों ही very commonly asked MCQs. Phacomorphic, mature intumescent, phacolytic, hypermature Morganian. Okay, chalo, let's go to the next question. Very common question. Sunflower cataract is seen in. Where do we get to see sunflower cataract? Where do we get to see sunflower cataract? Yes, sunflower cataract is seen in Wilson's disease. So sunflower cataract is seen in Wilson's disease. Okay, let's discuss a few other one-liners here. If we are asked where do we get to see snowflake cataract, what will be our answer? Snowflake cataract. The same four options. Snowflake cataract is seen in diabetes mellitus. Snowflake cataract, diabetes mellitus. What is the name of the cataract seen in galactosemia? It is oil droplet cataract. So oil droplet cataract is seen in galactosemia. And what is the name of the cataract seen in myotonic dystrophy? It is called as Christmas tree cataract. Christmas tree cataract is seen, this is seen in myotonic dystrophy. So there are four one-liners here. Snowflake cataract, diabetes mellitus, oil droplet cataract, galactosemia, Christmas tree cataract, myotonic dystrophy, and sunflower cataract, Wilson's disease. Right? Chalo, let's go to the next question. Where do we get to see posterior lenticonus? Posterior lenticonus means what? The posterior surface of the lens is conical like this. Where do we get to see posterior lenticonus? So where do we get to see posterior lenticonus? Posterior lenticonus is seen in Lowey's syndrome. Lowey's syndrome is a condition where you get to see cataract with posterior lenticonus. Another one-liner that can be asked from here is, where do we get to see anterior lenticonus? Where do we get to see anterior lenticonus? And the answer is, anterior lenticonus is seen in Alport's syndrome. So posterior lenticonus in Lowey's syndrome and anterior lenticonus is seen in Alport's syndrome. Okay? Chalo, next question. Where do we get to see sauce and cheese retinopathy? Sauce and cheese retinopathy, the other name for this is pizza pie retinopathy. So sauce and cheese retinopathy or pizza pie retinopathy, this is typically seen where? This is typically the appearance of the retina that you get to see in cytomegalovirus retinitis. So in patients who have advanced AIDS and very, very low CD4 counts, there you get to see cytomegalovirus retinitis, and the typical appearance of this is called as sauce and cheese retinopathy or pizza pie retinopathy, where you have multiple areas of white and red, so hemorrhages and areas of retinal whitening. So see, some patches of white will be there in the retina and some patches of red, and hence the name sauce and cheese or pizza pie retinopathy. So advanced AIDS patients with low CD4 counts presenting with sauce and cheese retinopathy or pizza pie retinopathy, it is CMV retinitis. Okay. Another one liner, let me tell you which organism with the infection of which organism is typically described as headlight in fog appearance. Typically described as headlight in fog appearance. So headlight in fog appearance, this is the typical description of Toxoplasma retinochoroiditis. So toxoplasmosis or toxoplasma retinochoroiditis, this is typically described as headlight in fog appearance. So in headlight in fog appearance, what happens is that there is lot of the retina and the vitreous both are involved. So there, because of the vitritis, there is haziness, so that looks like the fog, and the area where the retina is involved, that is bright, so headlight in fog appearance. So please remember this, toxoplasma retinochoroiditis, this is typically described as headlight in fog appearance. Important MCQ, one liner. Next question. Where do we get to see recurrent anterior uveitis with low back pain in an HLA-B27 positive patient? So recurrent anterior uveitis, patient has low back pain and he is positive for HLA-B27. Very, very, very typical question. Multiple times it has been asked in different ways. This is exactly the description of a patient who has ankylosing spondylitis. So usually the question may also mention that it is a young male patient. So a young male patient presents with bilateral recurrent anterior uveitis. He has long-standing history of low back pain. And on evaluation, he turns out to be HLA-B27 positive. So young male patient, low back pain due to involvement of sacroiliac joint, recurrent anterior uveitis which is often bilateral and positive for HLA-B27. This is typically, yes, ankylosing spondylitis. Again, commonly asked MCQ. Next question. What is the drug of choice for uveitis? Chalo, very, very simple question. Tell me. Is it atropine, steroids, antibiotics or anti-VEGF? What is the drug of choice for uveitis? Simple question. What is the drug of choice? It is an inflammation, right? So therefore, what will be the drug of choice? The drug of choice is steroids, because steroids are going to suppress or take care of the inflammation. So drug of choice for uveitis is steroids. Make no mistake about it. It is steroids. Some students feel that it is atropine, but please remember that atropine is an adjuvant. Atropine is not going to change the course of uveitis, so it cannot be the drug of choice. So why do we give atropine? Atropine is a cycloplegic, meaning it relaxes the ciliary body and hence it is responsible for pain relief. So it relieves the pain. So the drug of choice for uveitis is steroids. Atropine is the adjuvant of choice. Atropine is a cycloplegic and it helps to relieve the pain. So do not make the mistake of marking atropine as the drug of choice for uveitis. Drug of choice for uveitis has to be steroids, because that is only going to take care of the inflammation. Atropine needs to be given to relieve the pain, but it is an adjuvant. Okay? Chalo, let's go to the next one. Where do you get to see Dallen-Fuchs nodules? In which of these conditions? So sympathetic ophthalmitis, VKH disease, ankylosing spondylitis or sarcoidosis. Okay, Dallen-Fuchs nodules are typically seen in sympathetic ophthalmitis. Now, what are Dallen-Fuchs nodules? They are large granulomatous lesions in the choroid and they are typically described in sympathetic ophthalmia. What is sympathetic ophthalmia? Sympathetic ophthalmia means that there is a severe trauma to one eye, as a result of which a severe uveitis is developing in the other eye. So there are 2-3 questions which you need to know, one-liners about sympathetic ophthalmitis. First is, what kind of trauma can precipitate or lead to sympathetic ophthalmitis? Please remember that it is penetrating injury. So injury with a sharp object. And penetrating injury to which part of the eye? To the area of the ciliary body. Penetrating injury, the part of the eye that needs to suffer the injury is the ciliary body. So any kind of injury will not lead to sympathetic ophthalmia. So penetrating injury to the region of the ciliary body, this can lead to sympathetic ophthalmia. So what is the earliest symptom and the earliest sign of sympathetic ophthalmia? Because see here, what happens is one eye is already affected because of trauma, and the uveitis is actually developing in the other eye. So we have to keep on monitoring the other eye. So what is the earliest symptom? The earliest symptom, please remember, is difficulty in near vision due to loss of accommodation. Difficulty in near vision due to loss of accommodation. This is the earliest symptom. Difficulty in near vision due to loss of accommodation. And what is the earliest sign? Difficulty in near vision due to loss of accommodation. This is the earliest symptom. And we are often asked, what is the earliest sign? This is also another important MCQ. Please remember, the earliest sign is retrolental flare. Retrolental means behind the lens, and flare means turbidity. So turbidity or haziness behind the lens, this is the earliest sign. So I'll just go over all the MCQs once again. Which type of trauma causes sympathetic ophthalmia? The answer is penetrating trauma. Trauma to which part of the eye? Answer is ciliary body. Earliest symptom, difficulty in near vision due to loss of accommodation. Earliest sign, retrolental flare. And what do you see in the choroid? You see large granulomatous lesions in the choroid, which are called as Dallin-Fuchs nodules. All these have been asked and can be asked again. Okay, chalo, let's go to the next question. Where do you get to see 100-day glaucoma? So 100-day glaucoma, or in some books it says 90-day glaucoma. This is one of the important complications of, so it's a glaucoma which happens after a period of about 3 months. 3 months, 100-day glaucoma or 90-day glaucoma. Correct. This is typically the presentation of this is typically one of the complications of CRVO, central retinal vein occlusion. So 100-day glaucoma or 90-day glaucoma, that is, what type of glaucoma is it? This is a type of neovascular glaucoma. This is a glaucoma which is caused by neovascularization. So hence the name neovascular glaucoma. 90-day glaucoma or 100-day glaucoma which happens. So neovascular glaucoma occurring as a complication of central retinal vein occlusion. It happens after about 3 months and hence the name. Okay, chalo, next question. Where do we get to see cattle track sign? So cattle track sign and cherry red spot. Remember both of these. Cattle track sign and cherry red spot, both these are seen in right CRAO, central retinal artery occlusion. So central retinal artery occlusion presents with cherry red spot, which means that the whole retina is pale and only the fovea is bright red. And there is a segmentation of the blood column in the occluded blood vessel, that's called as cattle track sign. So segmentation of the blood column, this is called as cattle track sign. Segmentation of the blood column, cattle track sign. Chalo, next question. Where do you get to see Hages Dry? Where do we get to see Hages Dry? So Hages Dry are typically seen in ophthalmos. What are they? They are striae in the descemet's membrane of the cornea. They are striae in the descemet's membrane of the cornea, which are because of the stretching of the cornea. And what is their direction? They are horizontal in direction. So striae in the descemet's membrane which are horizontal in direction, they are called as ophthalmos. And one more type of striae which is asked is walked striae. So out of these conditions, where do we get to see walked striae? Please remember, walked striae are seen in keratoconus. They are also striae in the Descemet's membrane only due to the stretching of the cornea, but they are vertical. So see, we remember it as H for H and V for V. So half striae in the Descemet's membrane, they are horizontal. Walked striae are also striae in the Descemet's membrane, but they are vertical and they are seen in keratoconus. So half striae in congenital glaucoma or ophthalmus. Half striae in congenital glaucoma or ophthalmus and walked striae in keratoconus. Okay, chalo, let's go to the next question. In which type of cataract do we get to see polychromatic luster? So polychromatic luster, also breadcrumb appearance, a granular appearance called as breadcrumb appearance, and multiple colors which are called as polychromatic luster. Both of these, where are they seen? So polychromatic luster and breadcrumb appearance are typically seen in complicated cataract. Complicated cataract, that is cataract due to other ocular diseases. Like for example, you can see it in different types of complicated cataract, like cataract due to chronic uveitis, etc. etc. So, okay, breadcrumb appearance and polychromatic luster. These are typically described in complicated cataract. Next. What is the most common cause of unilateral proptosis in children? Very, very, very important MCQ. What is the most common cause of unilateral proptosis in children? So proptosis in children is usually unilateral, and the most common cause of this is orbital cellulitis. Orbital cellulitis is the most common cause of unilateral proptosis in children. And the most common cause of unilateral or bilateral proptosis in adult. What is the most common cause of unilateral or bilateral proptosis in adult? So, most common cause of unilateral or bilateral proptosis in adult is thyroid ophthalmopathy. Okay, so please remember this. Most common cause of unilateral proptosis in children. In children, proptosis is usually unilateral and it is acute onset. It's orbital cellulitis. In adults, proptosis is bilateral usually, but it may begin unilaterally. So therefore, most common cause of unilateral or bilateral proptosis in an adult patient is thyroid ophthalmopathy. Okay, chalo, let's go to the next question. What is the most common intraorbital tumor in an adult? Or I should say, what is the most common benign intraorbital tumor in an adult? So the most common benign intraorbital tumor in an adult is cavernous hemangioma. Most common benign intraorbital tumor in an adult. And if we are asked what is the most common benign intraorbital tumor, what is the most common benign intraorbital tumor in a child? The answer is dermoid. The most common benign intraorbital tumor in a child, it is dermoid. Okay, so most common benign intraorbital tumor in an adult is cavernous hemangioma. Most common benign intraorbital tumor in a child is dermoid. And most common orbital malignancy in a child is rhabdomyosarcoma. Okay, so most common benign intraorbital tumor in a child, dermoid. Most common orbital malignancy in a child is rhabdomyosarcoma. All these are really, really important questions. Chalo, next question. Very simple. What is the most common intraocular malignancy in a child? Most common intraocular malignancy in a child. I think everybody knows this. Yes, the answer is retinoblastoma. Most common intraocular malignancy in a child. The answer is retinoblastoma. Next question. What is a stye? What is a stye? Yes, a stye is an acute infection of the gland of Zeiss. Yes, it's an acute suppurative infection of the gland of Zeiss. Now, the other name for stye is external hordeolum. So, instead of giving stye, they can also give us in the question external hordeolum. This can also be given in the question. So, stye or external hordeolum, this is an acute infection of the gland of Zeiss. And another question that comes is, what is internal hordeolum? So please remember, internal hordeolum is an acute infection of the meibomian gland. So Stye is an acute infection of the gland of Zeiss. Internal hordeolum is an acute infection of the meibomian gland. And what is this? A chronic granulomatous inflammation of the meibomian gland. This is a chalazion. So all these three can be asked as questions. A chronic granulomatous inflammation of the meibomian gland is chalazion. So acute infection of the gland of Zeiss is Stye or external hordeolum. Acute infection of the meibomian gland is internal hordeolum. And chronic granulomatous inflammation of the meibomian gland is a chalazion. Okay. Next question. What is the most common site of obstruction in congenital dacryocystitis? The other name for congenital dacryocystitis is what? It is congenital NLD block. Congenital NLD block. So most common site of obstruction in congenital dacryocystitis or congenital NLD block. What is it? It is the lower end of the NLD, that is the valve of Hassner. The valve of Hassner. So where is the valve of Hassner? It is at the junction of the NLD with the nose. The junction of the nasolacrimal duct with the nose. At that point we have the valve of Hassner, and that is the site of obstruction in congenital dacryocystitis. And what is the treatment? The first line of treatment for a congenital dacryocystitis is sac massage, lacrimal sac massage. This is the first line of treatment. This is also asked. So the most common site of obstruction is the lower end of the NLD, that is the valve of Hassner. The first line of management is lacrimal sac massage. Right? Let's go to the next question. What is the primary function of the superior oblique muscle? Now for this, please remember that for obliques, the primary function is always torsion. So they are rotatory muscles. Okay, and we remember this as the mnemonic SYN. What is SYN? SYN stands for superiors are intorters. SYN means superiors are intorters. So for the primary function of the superior oblique muscle is intorsion. Primary function of the superior oblique muscle is intorsion. Okay, so let us learn up what are the primary functions of superior rectus, inferior rectus, superior oblique and inferior oblique. Right? So see, for superior oblique, I told you the primary function is intorsion, that is inward rotation. Similarly, for the inferior oblique, it is going to be extorsion, that is outward rotation. So SO primary function is intorsion, IO primary function is extorsion. Now let's look at SR and IR. So for superior rectus and inferior rectus, for superior rectus the primary function is elevation, and for inferior rectus the primary function is depression. So superior rectus elevation, inferior rectus depression. And for the obliques, please remember primary function is always rotatory movement or torsion, and SYN, that is superiors are intorters. Okay, so primary function of SO is intorsion. Okay, chalo. Next question. The posterior limit of the orbital floor is formed by, very, very, very important question. The posterior limit of the orbital floor is correct. It is formed by the palatine bone. So the orbital floor in front, it is formed by the maxilla. So in front it is formed by the maxilla, the orbital floor, and posteriorly it is formed by the palatine bone. So palatine bone behind. So maxilla in front and palatine bone behind. So the posterior limit of the orbital floor, this is formed by the palatine bone. So maxilla in front and palatine bone behind. Right? Chalo, let's go to the next question. In which layer of the retina are microaneurysms seen? So what are microaneurysms? Please remember, microaneurysms, these are the first detectable lesions in diabetic retinopathy. So first detectable lesion in diabetic retinopathy are microaneurysms. And in which layer of the retina are they seen? In which layer of the retina are they seen? Microaneurysms? Correct. They are seen in the inner nuclear layer. So microaneurysms are seen in the inner nuclear layer. Now taking the opportunity of this question, I will just discuss a few other MCQs or one-liners. So please remember, in the inner nuclear layer, two things are seen. You get to see microaneurysms and you get to see dot and blot hemorrhages. So both can be asked as question, like where are microaneurysms seen, where are dot blot hemorrhages seen. So both these, that is microaneurysms and dot blot hemorrhages, are seen in the inner nuclear layer. Next question that is asked is nerve fiber layer. So please remember, in nerve fiber layer also we get to see two things. What are they? You get to see flame shaped hemorrhages, that is the elongated intraretinal hemorrhages or the flame shaped hemorrhages. They are seen in the nerve fiber layer, and you get to see cotton wool spots. So flame shaped hemorrhages and cotton wool spots are seen in your nerve fiber layer. So please remember this. Okay? Next question. What does the nerve fiber layer of the retina contain? This again is very important. What is the content of the nerve fiber layer of the retina? And this nerve fiber layer of the retina, it eventually becomes the optic nerve. So what is it made up of, or what does it contain? Yes, the nerve fiber layer of the retina contains the axons of the ganglion cells. So the axons of the ganglion cells are located in the nerve fiber layer of the retina. Now see the cell bodies of the photoreceptors. These are located in the outer nuclear layer. Outer nuclear layer. ONL. The cell bodies of the bipolar cells, they are located in the inner nuclear layer. They are located in the inner nuclear layer. And the cell bodies of the ganglion cells, they are located in the ganglion cell layer. So inner nuclear layer, outer nuclear layer, and ganglion cell layer. Okay, please remember, so the axons of the ganglion cells are located in the nerve fiber layer of the retina. Okay, chalo, next question. Where do we get to see bony spicules or bony corpuscles? So bony corpuscles or bony spicules, where do they see? Where are they seen? Sorry. Correct. They are seen in retinitis pigmentosa or RP. So what is the triad of signs in retinitis pigmentosa? So the triad of signs is, please memorize this: pale disc, attenuation of the blood vessels, and bony corpuscles. Attenuation of the blood vessels and the bony spicules or the bony corpuscles. And the bony spicules, this is the triad of signs in retinitis pigmentosa. And what is the symptom? This is the triad of signs. And what is the symptom in retinitis pigmentosa? Retinitis pigmentosa, this is a dystrophy of the rod cells of the retina. So therefore it presents with what? What is the symptom? The symptom is nyctalopia, that is night blindness. Nyctalopia or night blindness is the symptom. Both these are MCQs. So retinitis pigmentosa, this is a dystrophy of the rod cells. So which cells of the retina are involved? Answer is rod cells. What is the symptom? The answer is nyctalopia. What is the triad of signs? Pale disc, attenuation of the blood vessels, and bony corpuscles. Okay, chalo, next question. What is the most common presenting feature of retinoblastoma? I think this is something you have to know like the back of your hand. Retinoblastoma, we just learned it is the most common intraocular malignancy in children, right? Sorry. So most common presenting feature of retinoblastoma, which is the most common intraocular malignancy in children. It is seen in children between 1.5 to 2 years of age. So children between 1.5 to 2 years of age, the most common presenting feature is leukocoria. What is leukocoria? Leukocoria means white pupillary reflex. So leukocoria or white pupillary reflex. Chalo, next question. Where does the sphincter pupily muscle originate from? So this is a commonly asked question. Both the sphincter pupili and the dilator pupili muscles, both of them, the sphincter pupili and the dilator pupili, both these muscles, they originate from the neuroectoderm. So I'll just tell you a few important things that are asked in the exam. Sphincter pupili, dilator pupili muscles originate from the neuroectoderm. Also the optic nerve and the retina. This is again common sense. All these also originate from neuroectoderm. So optic nerve, retina, sphincter pupili, dilator pupili originate from where? They originate from neuroectoderm. Important to remember, the crystalline lens, it originates from the surface ectoderm. And very important derivative of the sclera are the sclera and the extraocular muscles. These are important derivatives of the mesoderm. So these are a few important things that you need to memorize. So please remember, optic nerve, retina, sphincter dilator pupillary muscle, these are the ones that are asked. They originate from neuroectoderm. Crystalline lens originates from surface ectoderm. Sclera and extraocular muscles originate from mesoderm. There's a long list, but these are the ones that you have to know. They are asked in the exam. Okay, chalo, next question. What is the drug of choice for acute angle closure glaucoma? Acute ACG. What is the drug of choice for acute ACG? Please remember, the drug of choice is pilocarpine. Why pilocarpine? Because this pilocarpine, it constricts the pupil and breaks the acute attack. It constricts the pupil and breaks the acute attack. So it is the drug of choice. But this is not the first drug to be administered. Why it is not the first drug to be administered? Because it cannot act if the pressure is more than 40. So first you have to give a drug which is going to reduce the pressure, bring it below 40, so that pilocarpine can act. So if the question is, what is the first drug to be administered? The answer is mannitol. The first drug to be administered in acute ACG, this is mannitol. And what is the drug of choice? The answer will be pilocarpine. Okay, so what is the first drug to be administered? The first drug to be administered is mannitol because it decreases the pressure below 40. So the first drug to be given is mannitol. However, mannitol is only going to temporarily decrease the IOP. It's not going to solve the problem. So therefore, we cannot say it is the drug of choice. If we are asked what is the drug of choice, the answer will be pilocarpine. Okay, next question. Where do you get to see leash nodules? I think every one of you knows this. Leash nodules are seen in neurofibromatosis or NF1. These are very, very typical. These are seen in NF1 or neurofibromatosis. Okay, so these are the one-liners that I had. Now what I'll do is I'll quickly go through the important PYQs and then I'll go through a few important images. So chalo, let us just quickly go through this. This is an important PYQ. A child with history of malnutrition is examined and the following finding is noted. So why they have given history of malnutrition? They are suggesting that there is a deficiency of vitamin A. So vitamin A deficiency, that is xerophthalmia, and this xerophthalmia, it may cause a corneal ulcer, that is keratomalacia. The ulcer might perforate and then such kind of an anterior staphyloma may be formed. So the answer to this is anterior staphyloma. So vitamin A deficiency or xerophthalmia leads to corneal ulceration or keratomalacia. So the cornea ulcerates, perforates, and then you, as a result of this healing process, you get this kind of an anterior staphyloma. Right, so this is an important PYQ. Chalo. Let's go to the next question. A 7-year-old child is diagnosed with amblyopia. What is the line of management? What is the line of management? So what is the first line of management for children with amblyopia? It is occlusion. Occlusion therapy is the first line of management. Now, occlusion of which eye? Occlusion of the good eye. So which eye do we have to occlude? We are obviously not going to occlude the bad eye of the patient. We are going to occlude the good eye of the patient and force the child to use the bad eye. So you occlude the good eye and force the child to use the bad eye. Right? So treatment, first line of management of children with amblyopia is occlusion of the good eye. Next question. What is the treatment of choice for a recurrent pterygium? So the treatment of pterygium is excision, and the most common complication is recurrence. To prevent the recurrence, what is the best method? The best method is excision with conjunctival autograft. What is conjunctival autograft? Conjunctival autograft means you take a piece of conjunctiva from another place and you put it here. Right? So after you finish the excision, so if we are asked what is the treatment of pterygium, the treatment of pterygium is surgical excision. What is the most common complication of pterygium excision? The most common complication of pterygium excision is recurrence. And what is the treatment of choice for recurrent pterygium? The treatment of choice for recurrent pterygium is excision with conjunctival autograft. Right? Commonly asked question. Huh? A patient presents with sudden loss of vision and pain on eye movement. So the pointers in the question: loss of vision, pain on eye movement. Third, RAPD. RAPD means relative afferent pupillary defect, or they may mention Marcus gun pupil, because the other name for RAPD is Marcus gun pupil. So sudden loss of vision, pain on eye movements, RAPD, and central scotoma on perimetry. All this gives us a diagnosis of optic neuritis, that is an inflammation of the optic nerve. So because the optic nerve is involved, you get a loss of vision and you get RAPD, that's a pupillary defect, and a central scotoma. And see, because it is inflammation, you're going to get pain, that is pain on ocular movement. So what are the symptoms? Sudden loss of vision with pain on ocular movements. What are the signs? Decreased visual acuity, RAPD or Marcus gun pupil, and perimetry shows a central scotoma. So diagnosis is optic neuritis. Okay? Chalo. Let's go to the next question. A patient who has a history of trauma with vegetative matter presents with pain and photophobia. What is the likely cause? So see, this is they are talking about a corneal ulcer, and which type of corneal ulcer is expected when there is a history of trauma with vegetative matter. History of trauma with vegetative matter points towards a diagnosis of fungal corneal ulcer or fungal keratitis. And another thing they can mention is they can say that there is a corneal ulcer with satellite lesions. So this word satellite lesions also, if it is mentioned in the question, that is very, very, very suggestive of fungal corneal ulcer. Right? So trauma with vegetative matter, or if they say that there is an ulcer, there is a large ulcer with surrounding smaller lesions, or they say that there is an ulcer with satellite lesions, this also points towards a diagnosis of fungal corneal ulcer. Okay? Chalo, next question. A patient presents with BCVA, that is best corrected visual acuity, of more than 1/60 but less than 3/60 in the better eye. So what type of blindness? So see, BCVA in the better eye less than 3/60. That is what this means. So that is social blindness. So what is social blindness? That is BCVA in the better eye less than 3/60. This is also the WHO definition or the WHO criteria for blindness. So this also can come in the exam. So WHO criteria for blindness or social blindness is when you have BCVA, that is best corrected visual acuity, in the better eye less than 3/60. So what is economic blindness? Please memorize this. This is BCVA in the better eye less than 6/60. BCVA in the better eye less than 6/60. This is economic blindness. And what is manifest blindness? Manifest blindness means BCVA in the better eye less than 1/60. BCVA in the better eye less than 1/60. So BCVA in the better eye less than 6/60 is economic blindness, 3/60 is social blindness or WHO criteria for blindness, and 1/60 is manifest blindness. And BCVA in the better eye less than 6/18 is low vision. BCVA in the better eye less than 6/18. This is the criteria for low vision. This is the criteria for low vision. So all these four definitions, please memorize them. Okay? Chalo. Let's go to the next question. A patient presents with ptosis and on eating or sipping fluid, her ptosis decreases. What is the most likely diagnosis? So see, this is a very typical question, that there is a ptosis and there is a movement of the ptotic eyelid when the jaw is moved. So this is called as a case of complicated ptosis. Complicated ptosis is the category, and the typical name for this condition is Marcus Gunn jaw winking syndrome. So instead of complicated ptosis, they can also give Marcus Gunn jaw winking syndrome in your options. So there is a ptosis where there is a movement of the ptotic lid when there is a movement of the jaw, and hence the name Marcus Gunn jaw winking syndrome. That is the actual syndrome, and the category is called as complicated ptosis. Okay, next question. A newborn child presents with watering and photophobia, and this is the clinical picture. So I think what do you see in the picture? You see large blue eyes, right? So large blue eyes or large eyes with hazy cornea. It's not actually blue. The cornea is so hazy that it's looking like this. So large blue eyes or large eyes with hazy cornea. This is ophthalmus, that is congenital glaucoma. This is congenital glaucoma. So it's a newborn baby. The complaints are watering and photophobia, lacrimation and photophobia. And on examination, you see these kind of bilateral hazy cornea and the eyeball is large. So this is ophthalmus or congenital glaucoma. Okay, this question has come in FMGE, it has come in NEET PG. It's a very high likelihood of coming again. Next question. On looking through a pinhole, the visual acuity of a patient improves. What is the diagnosis? So this is a very common clinical test that we do in everyday, day-to-day clinical practice. So when you take the visual acuity of a patient and it is not 6 by 6, the next step you have to do is you have to put a pinhole. And if the visual acuity improves, meaning suppose it is 6 by 36, and then when you put a pinhole, suppose it improves to 6 by 6, right? So if this improves, then this is suggestive of refractive error. Very important. So if there is a visual acuity which improves with pinhole, then that is suggestive of refractive error. And suppose it doesn't improve, then it can be any of this: corneal opacity, retinal pathology, cataract, etc. So if there is an organic lesion, if there is an organic pathology like a cataract, a vitreous hemorrhage, a retinal pathology, a corneal opacity, so then the visual acuity will not change when you put a pinhole. So visual acuity improving with pinhole suggests refractive error, and visual acuity that does not improve with a pinhole suggests any kind of pathology, organic pathology like cataract, corneal opacity, retinal pathology, vitreous hemorrhage, etc. Okay? Let's go to the next question. A factory worker suffers trauma to the eye and there is an iron foreign body. So the trauma has happened with an iron foreign body. So what kind of foreign body is this? This is a metallic foreign body, right? So if you want to investigate or localize a metallic foreign body, what investigation should you use? We have to obviously use a CT scan. So what is the investigation you will do? The answer is CT scan. And they also ask what is the investigation that you will not do? The answer is MRI. So absolutely contraindicated is MRI. Why? Because this is a metallic foreign body. So for a metallic foreign body in the eye, what is the investigation of choice? The answer is CT scan. And what is the investigation that should never be done, or what is the investigation contraindicated for a metallic foreign body in the eye? The answer is MRI. Both these are asked. Which is the investigation of choice? Which is the investigation that is contraindicated? Both of them can be asked. Okay? Sure. Next question. Very simple question. A child who is 1.5 years old is presenting with this clinical picture. What is this clinical picture? See, this is leukocoria, that is white pupillary reflex. So 1.5-year-old child presenting with leukocoria, and USG shows mass with calcification. This is also another very important feature. So what are the 3 pointers in the question? Number 1 is the child is 1.5 years old. Number 2, it is leukocoria. Number 3, it shows intraocular calcification. Correct. So the answer is obviously retinoblastoma, which is, as we have learned, the most common intraocular malignancy in children. right? So shall we go to the next question? A tumor in the anterior pituitary causes pressure over the optic chiasma. So see, this is the optic chiasma. So if there is a tumor or any lesion that is compressing the center of the optic chiasma, what are we going to see? Correct. We are going to see bitemporal hemianopia. Very good. So bitemporal hemianopia, this is seen when there is a lesion in the optic chiasma. And where do we see homonymous hemianopia? Homonymous hemianopia is seen if there is a lesion in the optic tract. If there is a lesion in the optic tract, you get homonymous hemianopia. And where do you see homonymous hemianopia with central sparing? This is seen if there is a lesion in the occipital cortex. All these three can be asked in the exam. So please memorize: lesion in the optic chiasma, bitemporal hemianopia. Lesion in the optic tract, homonymous hemianopia. And lesion in the occipital cortex, homonymous hemianopia with central or macular sparing. So lesion in chiasma, bitemporal hemianopia. Lesion in optic tract, homonymous hemianopia. Lesion in occipital cortex, homonymous hemianopia with central sparing. ठीक है, चलो next question. A patient presents with meiosis, anhidrosis and mild drooping of the upper lid. So mild drooping of the upper lid means mild ptosis, right? So what are the three important features that are mentioned here? Mild ptosis, meiosis, anhidrosis. So when these three features are present, then what is the diagnosis? Yes, this is also something you have to know like the back of your hand. This is Horner syndrome. So they can give Horner syndrome in the options, or they can also give the technical name, that is the oculosympathetic palsy. Oculosympathetic palsy. So patient presenting with mild ptosis, meiosis, anhidrosis. Answer is Horner syndrome, also called as oculosympathetic palsy. Right? Chalo, next question. In which disease do you use corneal collagen cross-linking? The actual name of the procedure is corneal collagen cross-linking with riboflavin. Corneal collagen cross-linking with riboflavin. It is written as C3R or CXR, and this is typically done in which condition? Correct. It is done in keratoconus. So it is one of the procedures for flattening of the cornea in keratoconus. So in cornea, in keratoconus, the cornea is protruded and thinned out. So to flatten this protruded cornea, C3R or corneal collagen cross-linking is often used. So keratoconus, this is the disease where C3R is done, corneal collagen cross-linking with riboflavin. And why is it done? As I told you, it is used for flattening of the cornea. Okay, next question. What is the most common ocular presentation in patients of COVID-19? Or we should say that which part of the eye is commonly involved? That's how the question should have been framed. Which of the part of the eye is most commonly involved? The answer is conjunctiva. And what is the most common presentation? It is follicular conjunctivitis. So follicular conjunctivitis, this is the most common presentation of patients, ocular presentation on patients of COVID-19. So which part of the eye is involved most commonly? Answer is going to be the conjunctiva. So the most common ocular presentation is follicular conjunctivitis. Chalo, next question. Which is the most common ocular presentation of Marfan syndrome? Again, another very common and very important question. The most common ocular presentation of Marfan syndrome is correct. It is subluxation of the lens. So what is the position of the lens in Marfan syndrome? The position of the lens in Marfan syndrome is superotemporal. So there may be a superotemporal subluxation of the lens in Marfan syndrome. This is the most common presenting feature, or ocular feature, most common presenting ocular feature of Marfan syndrome. So in the eye, what is it that you get to see in Marfan? It is a subluxation of the lens or an abnormal position of the lens. And what is the position? It is superotemporal. Next question. What is the laser used in laser assisted cataract surgery? Which is the laser used in laser assisted cataract surgery? Right, it is femtosecond laser. So laser assisted cataract surgery. The actual name is FLACS, femtosecond laser assisted cataract surgery. So femtosecond laser assisted cataract surgery. It is, the actual name is femtosecond laser. Femtosecond laser assisted cataract surgery, or FLACS. Now where do we use excimer laser? Please remember this is used in LASIK, which is a refractive surgery. And where do we use ND-YAG laser? This is also very important. Please remember it is used for laser peripheral iridotomy. Where do we do a laser peripheral iridotomy? Where do we do a laser peripheral iridotomy? This is done for ACG, that is angle closure glaucoma. And we also do it for ND-YAG laser is used for laser capsulotomy. Laser capsulotomy, which is done, that is PCO, posterior capsule opacification, or after cataract. So please remember these. For laser assisted cataract surgery, it is femtosecond laser. For LASIK, it is excimer laser. For laser peripheral iridotomy and laser capsulotomy, it is ND-YAG laser. These are the important lasers and the laser procedures which are done in ophthalm. Okay, chalo, let's go to the next one. The test that is used here is, what is this test? I think this everybody will be able to answer. Yes, the name of this test is Schirmer's test. The name of this test is Schirmer's test. So what is this test used for? This test is used for evaluation of dry eye. So Schirmer's test, this is the very common test which is used for the evaluation of dry eye, and that is the picture that's given to us here. Okay, sure. Next question. A patient who has a previous history of cataract surgery complains of difficulty in vision, and this is the finding. So what is the finding that we see here? We see that the capsule has become opaque, right? So there is an IOL, and behind the IOL the capsule has become opaque. This is called as PCO, that is posterior capsule opacification. This is the name of the condition now. But sometimes instead of giving PCO in the option that is given is after cataract, which is the old name of the condition. Okay, which is the old name of the condition. So an elderly patient who has a previous history of cataract surgery, meaning he's complaining of difficulty in vision after cataract, and when you see this whitish opacity which is behind the lens. So it's an opacification of the capsule. So it's called as PCO, posterior capsule opacification. The old name of the condition was after cataract. Okay, chalo. What is this instrument used to assess? So this is a Placido disc. This is a Placido disc, and it is used for evaluating the corneal curvature and the corneal surface. So not just the curvature of the cornea, it can help to evaluate the corneal surface actually. So this is a Placido disc. Now what is the instrument for evaluating the corneal thickness? Please memorize this. The instrument for evaluating the corneal thickness is called as pachymeter. Pachymeter is the name of the instrument for evaluating corneal thickness. Now this is a Placido disc. It is meant for evaluating the curvature of the surface of the cornea. According to WHO classification, xerophthalmia X2 is. This is a slightly tough question. So X2 is corneal xerosis. Corneal xerosis. Okay, so see, the earliest symptom is this, night blindness. If we are asked what is the earliest symptom of xerophthalmia, it is night blindness, and it is written as XN. And what is the earliest sign? The earliest sign is conjunctival xerosis, and this is written as stage X1A. And what is the most definitive sign? The answer is Bitot spot, and it is written as stage X1B. And corneal xerosis is X2. And corneal ulceration or keratomalacia, that is X3. Corneal ulceration or keratomalacia, that is X3. So in short, this is your classification of xerophthalmia. So earliest symptoms of xerophthalmia is night blindness, XN. Earliest sign is conjunctival xerosis, X1A. Most definite sign is Bitot spot, that is X1B. And corneal xerosis or dryness is X2. And corneal ulceration or keratomalacia is X3. Okay? Now the last of the MCQs. What is the cause of hemorrhagic conjunctivitis? Again, common and important question. The most common cause of acute hemorrhagic conjunctivitis is adenovirus. So see, the causes are actually ACE. A stands for the commonest cause, that is adenovirus. Then you have Coxsackie virus. This is also a cause but less common. E stands for enterovirus and ecovirus. Enterovirus and ecovirus. So enterovirus is also a cause but not the most common. The most common cause of hemorrhagic conjunctivitis is adenovirus. Coxsackie virus, enterovirus and ecovirus are other causes, but most common is this, and that's why we are marking this as the answer. Okay, so this was a quick run through of questions that I feel are really important. Now what I'll do is I'll go through a quick run through of the important images. So let me have a look at the important images. So what is this vision chart? This is the most commonly used vision chart. I think you should be able to identify this. What is this? This is your Snellen's chart. This is the Snellen's chart. The Snellen's chart, which is for evaluating the visual acuity. So how do you identify it? See, the size of the letters becomes smaller and the number of letters increases as you go down. So the top line has one letter, then two letters, then three letters, then so on. Okay. So this is your Snellen's chart. So size of the letters becomes smaller, number of letters in each line increases. Next. What is this chart? This is also a visual acuity chart. Here, the size of the letters is becoming smaller as you go down, but the number of letters in each line is not increasing. Every line has 5 letters. This is called as the ETDRS chart, that is Early Treatment Diabetic Retinopathy Study Chart, because it was used in this study and hence the name. ETDRS chart or Early Treatment Diabetic Retinopathy Study Chart. This is also a visual acuity chart. The size of the letters becomes smaller as you go down, but the number of letters in each line is constant. Every line has 5 letters. Okay. Third, what is the name of this chart? This chart is a contrast sensitivity chart. See, the contrast or the brightness of the letters is decreasing as you move forward. So the name of this chart is Pelly-Robson chart. Pelly-Robson chart. This is a contrast sensitivity chart called as Pelly-Robson chart. Next, have a look at this chart. This I think everybody knows. This is what? This is the color vision chart. What is the name of this chart? This is the color vision chart. And what's the name of this chart? This chart is called as Ishihara chart. The color vision chart or the Ishihara chart. Okay. Next. What is the name of this instrument? The most basic instrument for evaluation of the anterior segment of the eye. This is used for evaluation of the anterior segment of the eye. And what is the name of this instrument? This is called as your slit lamp biomicroscope. This is your slit lamp biomicroscope, and this is used for evaluation of the anterior segment. So evaluation of the anterior segment is done with slit lamp biomicroscope. What is this? This is the Goldman applanation tonometer. This is your Goldman applanation tonometer. And what is the Goldman applanation tonometer used for? This is the gold standard for measuring intraocular pressure or IOP. This is the gold standard for IOP evaluation. Intraocular pressure evaluation, that is for measurement of eye pressure, intraocular pressure. This is the gold standard. So gold standard tonometer or gold standard for IOP evaluation is your Goldman applanation tonometer. Next, what is this? This is your direct ophthalmoscope. This is the direct ophthalmoscope. What is this used for? This is used for posterior segment evaluation or retina evaluation. So there is a handle, on top of the handle there is a head and there is a dial here at the side. A handle, there is a head and a dial at the side. This is the direct ophthalmoscope. It is used for posterior segment evaluation. The other ophthalmoscope is this. This is to be worn on the head. This is called as an indirect ophthalmoscope. This is also meant for posterior segment evaluation. So see, I told you anterior segment evaluation is done with the help of your slit lamp biomicroscope. Posterior segment you have DO, direct ophthalmoscope, and IO. These are the basic or the important ophthalmic instruments which you should be able to identify in the exam. Next, what is this? Very typical picture. Look at this whitish lesion that you see here. This is bitot spot. These are your bitot spots. Xerophthalmia, as we just learned, stage X1B. Okay, another important image. Have a look at this. What is this here? So see here, what do we get to see? You get to see a lesion which looks like this. See, you see an ulcer which looks like this. So a greenish lesion, linear, and it branches out like this. This is typically the picture of the dendritic ulcer. So a branching linear ulcer, this is the dendritic ulcer which is caused by herpes simplex virus. So this is typically the picture of HSV dendritic ulcer. So see why it appears to be greenish, because the ulcer has been stained with a dye which is called as fluorescein dye, and to get a good contrast we have put on the cobalt blue filter of the slit lamp. So this also can be asked, what is the dye used here? So the dye used here is fluorescein dye, and what is the filter that has been put on here? The filter that has been put on here is a cobalt blue filter of the slit lamp. And what is the diagnosis? It is the HSV dendritic ulcer. Next, what is this sign called? What is this sign called? This sign is called as Munson's sign. So what is Munson's sign? See, when you ask the patient to look down, the protruded cornea presses the lower lid. This is called as Munson's sign, and this is seen in advanced cases of keratoconus. Again, very important for IBQ. What is this sign? This is called as Munson's sign. When the patient looks down, the protruded cornea indents or presses the lower lid, seen in advanced cases of keratoconus. Next, what is this cataract that you see here? So in this, you see this kind of a flower-shaped whitish opacity. Like this is typically called as the rosette cataract. And where do we get to see a rosette cataract? Rosette cataract is seen in blunt trauma. So rosette cataract seen in blunt trauma, this is what it looks like. Again, another very important image for IBQ. Next, this has come recently. What is the name of this investigation? So in this investigation, the dye is seen inside the retinal blood vessels. So this is meant for the evaluation of the retinal vasculature. This is called as FFA. So fundus fluorescein angiography. So this is an image of FFA, that is fundus fluorescein angiography. FFA. Right? Next, very important image. See, the whole retina appears to be pale and only the fovea appears to be bright. So this is typically cherry red spot. This is something that you must know. It has come many times. Whole retina appears to be pale, only the fovea appears to be bright red. This is cherry red spot. Where do we get to see it? CRAO, central retinal artery occlusion. CRAO, central retinal artery occlusion. Next, look at this. The whole retina is full of hemorrhages. What is this called? This is called as your splashed tomato appearance. What is this? This is typically called as your splashed tomato appearance. And this is seen where? This is seen in CRVO, that is central retinal vein occlusion. So central retinal artery occlusion, that presents like this, cherry red spot, and central retinal vein occlusion, splashed tomato appearance. Whole retina is full of hemorrhages. Next, another important image, easy to identify. Look at the retina picture and see these black pigments here in the mid periphery. These clumps of retinal pigments, they are called as your bony corpuscles. So what is our diagnosis here? The diagnosis is retinitis pigmentosa. So clumps of retinal pigments in the mid peripheral retina, these are our bony corpuscles, and the diagnosis is RP, retinitis pigmentosa. Okay, a few pictures of a few of visual field defects. So what is this? When we get a visual field defect, we will mark out the nasal and the temporal fields. So the one towards the center is nasal field and outside is temporal. So here see, the temporal fields of both the eyes are lost, right? So the blackening is on the temporal side. So what is this called? This is called as bitemporal hemianopia. So the temporal field of both the eyes are lost. This is called as bitemporal hemianopia. And what is the site of the lesion? We have just discussed. The site of the lesion is the optic chiasma. So site of the lesion is optic chiasma. So blackening on the temporal side. Now correspondingly, have a look at this. Here also if I mark out nasal and temporal, you will see that the nasal field of one eye and the temporal field of the other eye are involved. So one eye nasal field, other eye temporal field. What is this called? This is your homonymous hemianopia. And where do we get to see this homonymous hemianopia? This we have just revised. It is seen if there is a lesion in the optic tract. So lesion in the optic tract, we get homonymous hemianopia. Another images, look at this. This is easy to identify. See, the central area is clear. So what is this? This is your central sparing. Homonymous hemianopia with central sparing or macular sparing. So where do we get this? This is seen if there is a lesion in the occipital cortex. If there is a lesion in the occipital cortex. So look at these three images. Bitemporal hemianopia, optic chiasma, homonymous hemianopia, optic tract, central sparing, occipital cortex. One more field defect, have a look at this. So here see, what do you see? You see one half of the field is lost like this. The blackening is in one half of the field. This is called as your arcuate scotoma, or it is called as your Jerem scotoma. So arcuate or Jerem scotoma, and where do we get this arcuate or Jerem scotoma? This is seen in glaucoma. Arcuate or Jerem scotoma, this is seen in glaucoma. Okay, chalo, next image. What is this? We have seen this large blue eyes. Yes, this is ophthalmus or congenital glaucoma. Ophthalmus or congenital glaucoma. Very, very, very typical image. Next, have a look at this. See, there is a swelling of the eye and you see this pus point at the lid margin. What is this? This is your stye. So the point of maximum tenderness or the pus point is at the lid margin. Similar picture, this. Here see, the maximum tenderness is away from the lid margin. So the maximum swelling or this is away from the lid margin. In the previous picture, the pus point was at the lid margin, or the maximum tenderness is at the lid margin. So this is a stye because it involves the gland of Zeiss, which is at the lid margin. Now, if you have a red swelling like this, where the maximum swelling or tenderness is away from the lid margin, then this is an involvement of the meibomian gland. So this is internal hordeolum. Because see, the meibomian gland is away from the lid margin. So that's why your maximum swelling or tenderness is away from the lid margin. So these two are acute infections. Now if you see this kind of a swelling, see, this is a swelling which is not red and it is away from the lid margin. So it's involving the meibomian gland and it is chronic. So what is this? This is a picture of chalazion. This is a picture of chalazion. So see, it's involving the meibomian gland. How do we know that? Because it is away from the lid margin and it is not red. So it's not acute, it's chronic. So it's chalazion. Now for incision and curettage of the chalazion, these are the instruments we use. So what are the instruments? See this one. What is this? This has come in the exam already. This is your chalazion clamp. This is the chalazion clamp that is used for incision and curettage of chalazion, and this is your chalazion scope. So chalazion clamp and chalazion scoop used for incision and curettage of chalazion. Okay, next question. What is this? Look at the lower lid. What can you see? You can see that the lid margin is turned inwards and therefore the lashes are rubbing on the surface of the cornea. So what is this? This is entropion. This is entropion. The lower lid margin is turned inwards and you can see the lashes rubbing on the surface of the cornea. So lid margin turned inwards. This is entropion. Opposite of this one, the lid margin is turned outwards. So see, the conjunctiva is exposed. This is ectropion. The lid margin is turned outwards and so the conjunctiva is exposed. This is ectropion. So this one entropion, this one ectropion. What is this? What do you see in this? See these white dots here, these are called as keratic precipitates. So these are inflammatory deposits on the corneal endothelium. They are called as keratic precipitates. And where do you see this? This you see in anterior uveitis or iridocyclitis. This is seen in anterior uveitis or iridocyclitis, that is inflammatory deposits on the corneal endothelium which are called as your keratic precipitates. And this is our last picture. What do you see this? What do you see here? You see the pupil which is irregular due to the formation of posterior synechiae. What is this pupil called? This is called as a festooned pupil. And where do we see this usually? This we see in cases of chronic uveitis. So chronic or recurrent uveitis, there you can get this kind of a festooned pupil. So not recurrent or chronic uveitis. Recurrent or chronic uveitis, you get to see this kind of a festoon. Okay, so these are a few images that I felt that we should revise just before the exam. So I have tried to compile the important one-liners, the important PYQs and a few important images which I feel have probability of coming in the FMGE exam. So see, opthal is one of the most scoring subjects. So I would want you all to go through all the important PYQs and look at the real obvious kind of images. Opthal images are usually very telltale. There is no confusion about the images. Very obvious images are given in the exam. So go through the images that have been given in the past few years. Go through the PYQs and the PYQ topics. And please keep your calm during the exam because that's very, very, very important. So all the very best for the exam. So please keep your calm in the exam, read the questions and the options carefully and then only mark the answer. Do not be in a hurry to mark the answer. Read the question, read the options and then only mark your answer. All the very, very best for the exam. And we are having some FMG tests for your practice on the app. So these are the dates of the FMG test. So this will help you get into that groove of the exam and this is going to help you in the process of feeling more confident for the exam. Right? So thank you very much for being a part of this session. I hope this will help you for your exam. And we will be having other subjects every day in this FMG Sprint revision series. So do join in tomorrow again for the next session. And thank you very much. Bye-bye and all the very, very best.